Good afternoon. My name is Elizabeth Herman from FHI 360. I work with EPIC Tanzania project. So as he introduced me, I'm going to present to you an abstract with the title Community Index Testing Effectively Reaches Children of Female Sex Workers and of Other Vulnerable Population. So first I'm going to explain to you in terms of our country profile. For Tanzania, our HIV prevalence is 4.8, whereby it's higher among women when you compare it with men, which translates to 1.7 million people who live with HIV in Tanzania. Currently, the HIV new infection is 10,000, which translates to 12% of the adolescents ages 10 to 19 years. And in terms of we are at 92% of pregnant women who are enrolled in ART for PMTCT. And for mother-to-child transmission rate, we are at 11%. In Tanzania, currently, we have several strategies. We make sure that the adolescent girls and young women attain prevention education, and all pregnant women are tested during antenatal clinic and during delivery, and we also have retests. But we still have a gap, and we as a community partner, we try to close the gap by testing these children through our community services. So we have 860,000 orphans who are due to AIDS and ages 0 to 17 years. And in terms of 95 of 95, in Tanzania we are above 80, 88% of people know their status, 86 are on treatment, and in terms of viral suppression, we are at 83%. Tanzania pediatric HIV country profile, it is estimated that 96,000 children who are ages 0 to 14 are living with HIV in Tanzania, and this is a significant number, highlighting to the ongoing need for the HIV prevention services and treatment efforts, especially for the vulnerable children. Data shows that the number of new infections in children has decreased significantly in Tanzania over the past years. In 2015, there was 14,000 new infections in children, while in 2021, that number has decreased by 30%. This is a positive trend that suggests that HIV prevention efforts are having an impact. And also data shows that early infant diagnosis has improved remarkably in Tanzania by 4.6%. This is important because early infant diagnosis help us to ensure and to attain timely identification, treatment, and care for the vulnerable children. While HIV remains challenged, it's important that we continue the prevention efforts, especially for the children that are from key and vulnerable population. And for the 395, Tanzania, we had 60 for the first 95, we're at 60 also for the second 95, and we're at 55% for the third 95. For EPIC Tanzania, just to explain to you more, EPIC Tanzania project is a 7-year project that's funded by PEPFAR and USAID. We currently operate in 11 regions in Tanzania, and our main focus, we give technical assistance, we provide direct service delivery in order to improve case identification, prevention, treatment, and virus suppression. Our primary targets are key and vulnerable population, which include female sex workers, men who have sex with men, and adolescent girls and young women. Our secondary targets are other risk men and women, and children who are tested through index testing. So the objective of this abstract was to describe the progress and gaps in achieving the first 95 among children, and the second objective was to quantify the contribution of community index testing of KVP to reaching infected children. So these are among our modalities that we do in EPIC Tanzania. We do HIV self-tests, which help us in reaching the hard-to-reach population. We do mobile and moonlight testing. We also do index, and together to to provide an opportunity to reach more KVPs and their children. We also do risk network referral and enhanced peer outreach approach. This risk network referral is an approach that for a HIV KVP positive identified is given an opportunity to identify a social network apart from their sexual partners. Enhanced peer outreach approach is an approach which is purely led by peers, and peers provide coupons to their KVPs who hardly access health services and who are hard to reach, whereby the coupons have healthcare providers' numbers and peers' numbers, so which gives them an opportunity to come back and to go back to the provider within the nearby facilities to being provided with comprehensive HIV testing services. So for index testing, which that is done by EPIC, we offer index testing services to the positive newly identified client, to the high viral load, and those clients who have interruption to treatment, whereby they identify their sexual partners and their biological children. These contacts are reached by the healthcare providers by the help of peers, navigator, and peer educators. After being reached by the providers, they are being provided with comprehensive HSTS, and the positive identified are linked to care and treatment, whereby the negative clients are being offered prevention services that include PrEP and condom. So we really sensitize on female sex workers, adolescent girls, and other risk women that are HIV positive to elicit their biological children, whereby after elicitation they are reached for testing, and they're also referred to other services like OVC services. So this is the methodology for the abstract, whereby we sampled 33 actively conducting index testing services districts, and these districts were sampled based on the number of children that were tested during index, and we also sampled all the health facilities within the district that reported index testing for children that were reached. All the children of female sex workers, adolescent girls, and young women were involved, and all the children that were tested through facility index testing services. And this was a period of October 2021 to December 2022. Our data sources, we used routine data that were captured by the healthcare providers from the HTS registers, and the data that were entered in the National HTS DHS2 database under the respective index testing modality by age and sex. We also used community index data that were captured in the DHS2 database with KVP children details. So for our data analysis, we compared case finding rates between the children of KVP who were tested through community index testing services and the children who were tested through facility index services by proportion and odds ratio. We analyzed the case finding rates by 5-year age bands, and we also used chi-square to test the significance of the case finding between the community index and facility index. So the result, as we can see, we saw that we had higher case finding rates among children that were tested through community index when you compare it with children that were tested through facility index, and the odds of identifying a HIV positive child through community index was 3.5 times higher than that of facility index testing. As we can see here, we have higher case finding rates among children that were tested in community index testing, which cut across in all age bands. If you compare it with the facility index testing, it is threefold. And we're also seeing higher case finding rates among children that ages below 5 years that were tested through community index testing. So our discussion, we came to a discussion that offering services to people living in HIV actually contributes highly to case identification among biological children. And because of the stigma, self-stigma, and the criminalization around female sex workers, which actually limits them to access health services. It's very important to use community index testing to reach them at their context and to provide them with HIV testing services. So community index testing services is contributes highly, as in EPIC Tanzania, the healthcare providers are trained on KVP-friendly services, and also we really use peer navigators and peer educators, which facilitate community index testing for children. And as we saw that community index testing yielded a higher case finding rate rather than facility index testing, and community index testing tailored approach is crucial for reaching children of KVP, especially those of 0 to 5 years old. So our recommendation is to scale up community index test services, as it helps to reach children of KVP who may not actually present at our health facilities, and to make sure that they are being tested within 2 weeks with fidelity. Also, we recommend collaboration with OVC implementing partners who really helps to reach those children that were elicited and are not reached, and to facilitate referral of HIV testing services. We also recommend advancing policies like HIV self-test for adolescents and children, especially who are aged 10 to 14, which using this HIV self-test really increases coverage of index testing among the children of KVP. That's all. Thank you.